I'm also curious, the payer side of things always comes into this. So, we have biomarkers that have been approved. Now we have drugs that are available, but there always is the challenge of having the actual implementation, of healthcare and the paying for those treatment services matching up with the available science. So, Jeff, how are you seeing the world of payers, and are they embracing these biomarkers? Are they embracing the treatments? How are we going to make sure that the science that's coming forward and the research and the breakthroughs that are happening are actually going to get into the lives of families so that they're going to be paid for by health insurance companies?
A very important part of the availability of new drugs is that there is payment for them. And we're fortunate in the United States that CMS is paying for a large portion of the cost of monoclonal antibody therapy, and they are paying for the cost of the amyloid scan that establishes the presence of amyloid in the brain. Now, that will probably shift towards a blood test now that a new blood test has been approved. But in many countries, for example, just last week in the UK, NICE, which is their funding organization, decided not to fund donanemab and lecanemab. Well, that means that many patients will not be able to be treated. Or maybe when it's approved in 2 years, many of those patients will already be beyond the window of being able to be helped by these drugs. So we are fortunate right now that CMS has stepped up and has said, yes, we're going to pay for these drugs. The evidence is sufficient, and we hope that this can set a global standard.
So one thing I want to mention is that the misunderstanding that people have around disease modifying therapies really being very different than symptomatic ones, and this idea that we can evaluate disease modifying therapies based on whether or not there's a point difference that's clinically meaningful at a specific early time point. That same misunderstanding carries over to the pharmacoeconomic modeling that's used for disease modifying therapies. We've done quite a bit of work around pharmacoeconomic modeling of Alzheimer's disease with these monoclonal antibodies. And what you see is that when a treatment is given early and it prolongs an early stage of disease, and it's with a disease modifying therapy where the effect is maintained, and we have evidence that it's maintained by an off treatment phase where it's already maintained, you actually get a benefit for the rest of your life. What that means is if you have 18 months of treatment and you save people 5 months of progression, every milestone of the disease is now 5 months later than it would have been, even if they never take the treatment again after those 18 months. And if they continue taking it after those 18 months, there's evidence for lecanemab that the open label follow-on continues to aggregate benefit on top of that. And what that means, again, is that every single time you take the treatment, that benefit goes through the rest of your life. And if you factor in the cost savings of that through the rest of your life component, it's really very dramatic. If you just think of it as the benefit you have just today, then you're really underestimating how much these disease modifying therapies really make a difference. And we've put that modeling side by side, and the biggest thing that modeling shows is that early treatment is much, much better than late treatment because you're slowing it down when it's at a very slowly progressive stage. You're maintaining that highly functional stage as long as possible, and then they drop off later in disease, and presumably there will be competing causes of death at that point, and you may never even get to the point that they have the worst symptoms within their lifetime. And if you can prolong the time until nursing care is needed, until nursing home placement, and prolong the time that they're able to live independently, the cost savings to those communities is going to be enormous. So my feeling is that CMS has made the best decision, and that paying for these things will pay for itself. And so it's not just a question of being willing to invest in these patients and give them the benefit. It's actually going to pay for itself in the long run. And I think if NICE saw some of that modeling and saw that potential benefit, that they would realize that even in a healthcare system where it's paid for by NICE, that they would also have those cost savings and it would pay for itself.